What exactly is neurogenic bladder, and how do you manage it? Ever found yourself just going with the flow of bladder management and not knowing how to actively contribute? If so, you are not alone, and I've got you covered. In this video, we'll break down what OTs need to know so you can start making informed recommendations and help clients take an active role in their bladder management program sooner. We'll cover the two main types of bladder dysfunction in SCI populations and key bladder management strategies to enhance your practice and improve your clients' quality of life. Let's dive in. Welcome back to video number 2 in the series. We talk about the role of OT and BBM. I'm Julia, and today we're diving into bladder dysfunction, an essential bladder management program guidelines. To help you follow along, handouts and resources are linked in the video description below, providing extra guidance beyond what we'll cover in this video. If you're already familiar with neurogenic bladder and want to jump ahead to bladder assessment and intervention strategies, feel free to jump ahead to video 4 in the series. Otherwise, let's get started. Let's do a quick overview of the urinary system. The urinary system is divided into 2 parts. The upper tract, which consists of the kidney and ureters, which filter and transport blood, and the lower tract, which consists of the bladder and urethra, responsible for storing and emptying urine. Bladder function relies on 2 main muscle groups: the detrusor muscle, located within the bladder wall, which contracts to push urine out, and the sphincter muscles, which are ring-shaped structures in the urethra that control urine flow. In adults, normal bladder capacity is between 300 and 500 milliliters, typically the time that you start to feel the urge to urinate. Now, a quick note on anatomy. The male urethra is longer than the female urethra. In males, it passes through the prostate gland, which can enlarge with age and make catheterization more difficult. In these cases, a Coude tip catheter may be a better option, but more on that in video 5. When neuropathways between the brain and the urinary system are disrupted, we call that neurogenic bladder. There are 2 key pathways involved in urination. First, we have the micturition reflex arc, which is one of many other sacral reflexes. This automatic reflex serves as a communication circle between the bladder and the spinal cord. When the bladder fills, stretch receptors send signals to the sacral spinal cord, signaling the bladder muscle, the detrusor, to contract and the sphincter muscles to relax, allowing urine to empty. Next is the brain to spinal cord pathway. The pontine micturition center in the brain allows voluntary control over urination. It inhibits the reflex arc so you don't automatically void the second that your bladder fills. When these reflexes are disrupted, bladder function is either classified as reflexive or spastic, or areflexive and flaccid, depending on if that reflex is still intact. Let's start with reflexive bladder, also known as spastic bladder. This happens when there's an upper motor neuron lesion at or above T12. In these cases, the micturition reflex arc is still intact, so the bladder can empty involuntarily in response to stimuli, like bladder fullness or tapping on the lower abdomen. But even though the reflex is still working, 2 big issues can arise: retention and incontinence. With retention, this happens when the detrusor and the sphincter aren't communicating or coordinating properly. This is a condition called detrusor sphincter dyssynergia, or DSD. Instead of relaxing when the detrusor contracts, the sphincter stays closed, leading to urine retention or reflux back into the kidneys, which could cause serious damage. Meanwhile, incontinence can also be an issue, as an overactive detrusor muscle can cause unexpected leakage. So how do we deal with these problems? The short answer is catheterization. Using a catheter helps ensure that the bladder empties completely, preventing retention and potential complications. For incontinence, setting up a timed voiding schedule can help reduce accidents by establishing a consistent routine. Note, while outside the scope of OT, medications like anticholinergics can help suppress bladder spasms, and alpha blockers can relax the sphincter muscles to address DSD. However, our role as OTs will focus more on skill development for cathing and adherence to time voiding schedules. Next up is areflexive bladder, or flaccid bladder, which occurs below T12 or at the sacral level. Here, the detrusor muscle doesn't contract effectively, which leads to an underactive bladder muscle. This situation brings 2 main challenges as well. First is retention, where the bladder doesn't empty or empty fully, causing over-distension. And next is overflow incontinence, where the sphincter may remain open, leading to dribbling as urine builds up and eventually leaks out. To manage areflexive bladder, again, catheterization will be key. It helps prevent retention and ensures that the bladder empties properly. In cases where catheters aren't available, manual techniques like the Crede maneuver, which is applying pressure to the lower abdomen, or the Valsalva maneuver, which is bearing down, can help empty the bladder. However, keep in mind that these methods don't always empty the bladder completely. Leaving urine behind, also known as post-residual volume, can increase the risk of infection. Therefore, catheterization remains the preferred management strategy. So, if catheterization is the main strategy for both reflexive and areflexive bladder, why does this all matter? As an OT, understanding the type of bladder dysfunction helps you recognize why a client is experiencing bladder retention or accidents. So you aren't left guessing if and when things go wrong. Instead, if your client is having frequent accidents, you'll be able to educate them on what's happening and why. This means you can make informed recommendations, like adjusting time voiding schedules to prevent leaks. Next, you can help facilitate medical conversations, like encouraging clients to discuss medication options with their provider for managing bladder spasticity or conditions like DSD. The more that you can understand the why, the better you can support your clients in gaining confidence and independence in their bladder management. All right, let's throw in a curveball with spinal shock. Right after an SEI, the body goes into a temporary state called spinal shock, where all reflexes, movement, and sensation below the level of injury shut down. This can last anywhere from days to weeks before reflexes gradually start to return. So how do we know when spinal shock is over? The return of sacral reflexes. Healthcare providers will routinely check for these, especially the bulbocavernosus reflex, or BCR, or anal wink, because these are the first reflexes to come back. So what does this mean for the client? Until spinal shock resolves, we can't accurately predict long-term function or sensation. And here's a key takeaway. During spinal shock, both neurogenic bowel and bladder will act or behave like a lower motor neuron injury, meaning flaccid, areflexive function, even when cases will eventually present as an upper motor neuron lesion or that spastic reflexive bladder that we were talking about before. But here's the good news. If the sacral cord S2 to S4 is not directly damaged, sacral reflexes may return. If that happens, somebody with an injury at or above T12 with lower motor neuron-like symptoms will likely transition to upper motor neuron presentation. In the meantime, our focus will always be to meet the client where they are and maximize independence in their daily routine. I would be remiss if I didn't mention autonomic dysreflexia in this video, as it should be a key topic of education for your client. For individuals with injuries at or above T6, bladder issues, especially retention or UTIs, can trigger AD, which is a life-threatening condition that can be caused by an overactive autonomic nervous system. Signs of AD include a sudden spike in blood pressure, slow heart rate, pounding headache, and flushing and sweating at or above the level of injury. If you suspect AD during a session with the client, stop what you're doing right away and sit the client upright to help lower their blood pressure. Check for a blocked catheter or a full urine collection bag or other noxious stimuli. Of course, there are a myriad of other AD triggers that are not bladder related, which I'll link in the video description below. Ultimately, if symptoms persist, get medical attention right away. Understanding AD allows us to respond quickly and educate our clients on how to prevent it. All right, now that we've covered the basics, let's talk about some of the general bladder management timelines and guidelines. Usually when SEI patients arrive in acute care, they are initially set up with a Foley catheter for continuous drainage. By the time they transition to inpatient rehab, their bladder management program continues to evolve under our care. While every bladder management program is highly individualized, general strategies include clean intermittent catheterization, or CIC, time voiding, hydration education, medication management, and continuous monitoring. If possible, transitioning from an indwelling catheter to CIC is preferred because it reduces the risk of infection. For those not familiar with CIC methods, this involves a single-use catheter that is inserted for bladder drainage, then immediately removed when complete. Also, if you could do this in a seated position with a slight posterior pelvic tilt, you can take advantage of gravity and promote catheter access up the urethra into the bladder. And that's an emphasis on the slight posterior pelvic tilt. This may be more obvious for urethral access in females, but for males, sitting straight can create a 90-degree turn in the urethra, making it harder to feed a catheter into the bladder. Next, we have time voiding, establishing a routine to empty the bladder every 4 to 6 hours helps reduce risks of accidents and retention. With hydration education, encouraging proper fluid intake can prevent other secondary complications like bladder or kidney stones and infections. For medication management, you can help clients self-advocate to regulate bladder tone and spasms. And finally, through continuous monitoring, letting patients know that bladder programs can always be changed or simplified through different types of AE or catheter types. And teaching clients to recognize signs of complications is essential for long-term success. Eventually, individuals with SCI should go and see a urologist to have something called a urodynamic study completed. This test assesses bladder pressure, capacity, and overall function to help determine the best management plan. The results guide treatment decisions, such as catheterization techniques, medications, and other interventions to prevent complications and improve long-term bladder health. Well, that was a lot if you're new to bladder dysfunction and management. So here are 3 key points to remember. Catheterization is the foundation to neurogenic bladder management. Understanding reflexive and areflexive bladder can help individualize plan of care. And finally, preventing complications like incontinence, retention, and UTIs, just infections in general, is critical for long-term health. Join me next time as we go into bowel dysfunction and management strategies. Bye now.